Thank you very much, sir, for providing me the opportunity to talk about the majority of patients and the majority of stroke patients. The talk would be, sir, not on the management. I would just like to highlight that the number of patients and the problems they face who are not eligible for tPa. And I usually like to start my presentations with this. So this was this gentleman who over a very long period in the sea had no problems at all, and he had never seen anything in distress, and there was never any predicament. And you know who said this? He was the captain of the Titanic. So we think it won't happen to us or me here, but it will happen. Stroke will happen. As you see, sir, all neurology patients who do not have stroke are not eligible for tPa. They are not eligible for intervention. Even the substantial majority of stroke patients in all studies all over the world will not be eligible for tPa or intervention. But I'm for stroke, sir. I'm for acute stroke intervention. I'm for tPa. It should be done. It should always be done. So what is all the fuss about? So sometime in the past, sir, a consultant and a head of department, he asked me, do you admit stroke patients? And I thought to myself, is there an option? Should we not be admitting stroke patients? But possibly, yes. We should not be admitting stroke patients. There are evidence that certain types of stroke patients should not be admitted. But you know, for recognition for FCPS neurology, any hospital, it just needs to have 20 beds total. The whole neurology setup just needs to have 20 beds. So how many beds are dedicated for the non-eligible patients, the majority of the stroke patients? Yes, we hear about stroke units, and yes, we hear about hyperacute stroke units, and but what about the majority of the patients? Should then they be left to internal medicine? Should, like in UK, in many places, should geriatrics look after them? So we should look at it. 20 beds, looking at all of neurology, and how many for the non-eligible patients? I don't think hardly any. So we are at an age, and we have lived through what it used to be like in the past. Once we were doing our house job, we did not have CT scans. We were told that an ischemic and a hemorrhagic stroke should be differentiated on the basis of history, and certain points were there, and then someone would come out and say कि dyspnea तो देनी है, तो what difference does it make? But now usually the residents call us after a CT scan, after a lot of workup has been done in tertiary care settings, like in our setup. Stroke protocol is initiated. We have dedicated stroke teams. We have tPa, we have intervention. We have been doing it for more than 2-3 years. But you see the small print. So what about the non-eligible patients? They hardly get a mention. The resident will not even call for a patient who is not in the window for tPa. Most patients will not be admitted. Even if they are admitted because of complications. They are admitted because of aspiration. They are admitted because of other issues, maybe low GCS. And they will be seen in the routine. We should be looking after them. Of course, the problem is awareness. people don't know that stroke is preventable. They don't know it is treatable. They don't see symptoms, what to suspect, what are the after effects. There are long-term after effects, and with better organization, of course, lot can be done to transform stroke care. And there is a vacuum, and once there is a vacuum, other people will come. Cardiologists have started doing intervention. Should they be doing intervention? Do you want a cardiologist looking at your neurology? Do you want, like New Amsterdam, he said, do you want a gynecologist tagging in your heart surgery? So we need to look at this. You have a look at most guidelines, most areas, most recommendations. They will always come up that people with stroke should be admitted to the hospital. They should be treated by designated people, designated stroke unit. We should have physicians specializing in stroke medicines. And I'm talking about the majority of the patients. I'm not talking about the eligible patients. No. About the non-eligible patients. So we allocated the resources, have we allocated the beds. We need to have a look on that. So we are a poor country, and we have a resource limited setting, and cost of tPa is high. Yes, it is available. Very few public hospitals have that, but it is high. Cost of thrombectomy is even higher. So even with treatment, I know, yes, there's most people will benefit, but majority of all the eligible patients will still have some disability. They will still need to be looked after. The resources that we put in for non-eligible patients will help these eligible patients who will have disability. They will have aphasia, they will have problems in mobility, they will have problems in so what has happened? We have gone from stroke at one time to acute stroke to hyperacute stroke, and maybe we are improving our wording, and we are putting models of care in place. We have very fancy words, mothership model. You have a drip and ship model, and the latest one is the fit model. You fly, you have helicopters, you fly the intervention teams to rural areas, and can we afford it? Should we go down this line? Maybe yes, everyone should have probably the best of care, but is it feasible? Shouldn't we putting in more resources by recognizing that stroke is a chronic illness? It is not from all the material I see, stroke, acute stroke, acute stroke. So it is a chronic illness. Cardiovascular risk factors have to be sorted out. Medication has to be sorted out. Further prevention is to be done. Complications have to be prevented. But is it treated like that? It is not, unfortunately. So the cost of medicine, the availability of medicine, people don't know what to do. Then what about the further investigations? Can they have them done? They are expensive. They are not readily available. Have we put in our resources in having these things done? We should think of that. But the problem is that There are naturally some limitations, and there are some system flaws, and we have limited data. We as a country have limited data. We do not have any standardized functional assessment. Even if it is done, it is not done routinely. There are no standardized care plans. Yes, we say there should be rehab, but realistically, you know, how can a patient come for rehab in outpatient? We hardly have any facilities for providing rehab to the patient. There is a fragmented transition or transmission between care settings. One might be in a hospital one day, and the next day you are in the at home. And there is a total lack of community care and systems of support. So I'm almost at the end of my talk. My emphasis and my this issue is very close to my heart, that we should at least be looking after the majority of the patients. Yes, acute stroke patients will, of course, reduce the disability. It will reduce the long-term effects, the long-term economic effects. But the fact remains that even after all this intervention, stroke still remains the leading cause of disability, one of the leading causes of disability in the world. So, as they say, time is brain. So I will thank you, and maybe we need to have this approach. Maybe it helps the mobility. Thank you very much.